Welcome to my podcast, Why Didn't Anyone Tell Me This? With my guests, we are discussing reproductive health issues, questions you may have about your health, and debunking some of the many myths. And in this series on Beyond the Bleed, periods, endometriosis, PCOS, and more, it's a pleasure to talk to a long-time friend of mine, Professor Ertan Saridogan. I've been trying to pronounce trying to learn how to say that, about understanding endometriosis. Now, Ertan is a professor at University College London and a consultant in reproductive medicine and minimal access surgery at University College London hospitals. He is a past president of the British Society of Gynaecological Endoscopy and current president of the European Society of Gynaecological Endoscopy. His clinical interests include laparoscopic and hysteroscopic surgery for benign gynecological conditions, reproductive surgery, endometriosis, fibroids, and outpatient hysteroscopy. His research interests include non-invasive diagnosis of endometriosis, clinical outcomes following endometriosis surgery, outpatient hysteroscopy, and the place of screening and risk reducing surgery in women with a history of familial cancer. Ertan has been working on endometriosis since 1983. He is considered one of the world leaders in endometriosis and has co authored the three versions of the ESHRE, which is the European Society of Human Reproduction and Embryology guidelines on endometriosis. And he's invited to speak about endometriosis at many international conferences. Welcome, Ertan.
Hello, Joyce. Nice to see you.
Now, I'd love to start my podcast by asking my guests what led them to the career they are doing now. So, can you tell me why you wanted to be a doctor and what sparked your interest specifically in endometriosis?
Okay, yes. Interesting question. Um, well, from an earlier age, during my secondary school, high school years, I was interested in science, and I was very good at maths, biology, chemistry, and I wanted to choose a subject that I could easily put into practice and help other people. And choosing medicine was no brainer. It was the obvious option for me, so I went into medicine. So, in terms of my history with journey with endometriosis, obviously it starts in 1983. I was a year four medical student at that time. I was doing my rotation in obstetrics and gynecology, and I attended a lecture by one of the associate professors, Professor Kutay Biberoğlu. So some of us who are in the field of endometriosis will be familiar with Biberoğlu Berman scale, which is the father of the quality of life questionnaires that we use these days. So Professor Biberoğlu had just come back from Michigan, and I was studying medicine in Ankara. So he had just returned from Michigan, having completed a research project on medical treatment of endometriosis using danazol. Danazol is a historical treatment. And I found that lecture fascinating. And little did I know at that time that endometriosis was going to take up a lot of my time, rest of my life. And there we are. I'm still in the field of endometriosis since then. Danazol is no longer used in clinical practice, but endometriosis is very much relevant to millions of women around the world. Hence, the subject is of significant relevance to many of us.
Yes, and I bet you thought in 1983 that we'd be further along with the cure for endometriosis, but as we'll discuss today, it's not that simple, is it, to treat endometriosis?
Unfortunately, not. It's considered a chronic condition. So when we talk about treating endometriosis, managing endometriosis, we are not talking about curing it. We are talking about improving the symptoms, improving quality of life. Um, uh, Even after surgery, surgical excision, the symptoms may not go away altogether, and then there is a significant risk of recurrence after both medical and surgical therapies.
Yes, it's certainly complicated. So let's start by, can you explain what is endometriosis? And there are different stages. So what are the different stages?
So, endometriosis is presence of tissue similar to the lining of the womb being present outside the womb. When it is found outside the womb, it's called endometriosis. Sometimes it can be found in the muscle layer of the womb, and that is named as adenomyosis. So they are quite often found together, but their location is different. Endometriosis can be found anywhere in the body, but most commonly is found in the pelvic area, in the ovaries or on the surface of the ovaries, or around the structures around uterus, ovaries, fallopian tubes. But it can affect the digestive system. It is one of the most common additional non-gynecological sites. It can affect bladder. It can affect the upper abdomen, the diaphragm. You can actually, whatever tissue you can think of, endometriosis can be found there. Apart from the spleen, it's not clear why it's not described in the spleen. It may be something to do with its immune function.
And are
So
there
the
different
stages,
stages?
yes, stages. So obviously this is a kind of changing concept. Um, Traditionally, we use minimal, mild, moderate, severe endometriosis, but this is now becoming less popular, this approach, because there isn't a real correlation between symptoms and these stages that we use. For this reason, there are different approaches to describe the extent of endometriosis depending on the organs involved and also the nature of the lesion of endometriosis and size of the lesion. So endometriosis is quite often found in the pelvis, as I explained earlier, so that it may be like a superficial spot or superficial spots. We call it superficial or peritoneal endometriosis. It may be in the ovaries in the form of cysts, fluid-filled cysts, and we call them ovarian endometriosis. And then usually these cysts contain old blood, and old blood takes like a brown color, looking similar to melted chocolate. That's why they are quite often referred to as chocolate cysts. And then there is the concept of deep endometriosis when there is a mixture of scar tissue with tissue from the lining of the womb, and then they generate these solid lumps called nodules. So in other words, we are talking about three main types: superficial endometriosis, ovarian endometriotic cysts, and deep endometriotic nodules.
And what sort of problems will these cause women? What are the symptoms that they get with endometriosis?
So some women with endometriosis will have no symptoms, so it's not always symptomatic. It may be completely incidental, and uh, the woman may not have any symptoms. But when it does cause symptoms, um, the two groups of symptoms are either pain or fertility difficulties. Pain is usually during periods, uh, painful periods that we call as dysmenorrhea. Um, Pain during sexual intercourse, pain during opening bowels are three common types of pain that women with endometriosis may describe. Apart from this, especially in women who have suffered from endometriosis for a long time, pain may start occurring outside periods as well. So it may be constant pain, as we described, chronic pelvic pain. And depending on the location, we might see other types of pain. For example, if it's affecting the bladder, it can cause painful urination. If it's affecting the diaphragm, it can cause pain on the shoulder tip, usually during menstruation. So sometimes we see women with endometriotic nodules, lumps in the abdominal wall, or cesarean scars, and they usually describe pain in those locations, usually worsening during periods. So these are the common pain symptoms. And then the second group, as I mentioned, is difficulty in getting pregnant.
And so it seems to vary a lot between different women. Do we know why that is?
Obviously, there are different types, as I explained earlier. And secondly, location can make substantial difference. If it is located, for example, in the bladder, then inevitably the woman may dominantly suffer from bladder-related symptoms. If it's on the bowel, she is more likely to describe bowel-related symptoms. So that there is a lot of variation in terms of location. The other the issue is the extent of the condition. Sometimes the endometriosis may be relatively minor, minimal, and this may cause less symptoms, whereas with very extensive endometriosis, symptoms may be more substantial. Having said that, there is no direct correlation with the extent of endometriosis and severity of symptoms. Some women with relatively minor endometriosis may have very severe symptoms, and vice versa, women with very extensive endometriosis may have no or very little symptoms.
And Ertan, how common is it?
Well, so it's estimated that about 1 in 10 women have endometriosis in reproductive years. So if we look at women between ages 15 and 50, as we describe as reproductive years, therefore it's estimated like around the world, around 190 million women have endometriosis. Many of them may be asymptomatic without any symptoms, but this is the estimate. It's not always very easy to diagnose because sometimes diagnosis requires looking inside the abdomen with a camera or at open surgery. And because of that, we may have some women in whom we don't have the obvious diagnosis. Therefore, we are talking about estimates based on published research from various sources.
So I was going to ask you about diagnosis because we hear so often that women have taken years to be diagnosed. So if they have symptoms of
Yes.
pain, especially around their periods, and they go to their doctor, why would it take so long to get endometriosis diagnosed?
So the one issue is obviously awareness, lack of awareness amongst young women or women in general, lack of awareness amongst healthcare professionals, or the assumption that period pains are normal, so that that they are common in teenagers. As they become older, they'll disappear type concept can actually lead to ignoring these symptoms and not taking action in terms of exploring it, investigating it further, or trying to treat it. So these are probably common reasons why diagnosis may be delayed, lack of awareness. But the other reason is that quite often it is hidden in the pelvis, and um, and especially if it is like superficial spots or nodules that are difficult to see on imaging, the diagnosis may only be made when you look inside the abdomen with a camera, with endoscopy. It's an invasive investigation, and because of that, the diagnosis can take some years to make. Um, Therefore, we quite often hear complaints that women may have taken 10 years, more than 10 years to have a diagnosis. The average duration of delayed diagnosis these days seems to be calculated at about 8.5 years these days. Having said that, there has been improvements in terms of our ability to diagnose. We used to say that gold standard for diagnosing endometriosis was laparoscopy, endoscopic examination of the inside of the abdomen. But with advances in imaging technology, with high definition ultrasound examinations or MRI, magnetic resonance imaging scans, now we are able to diagnose endometriosis with quite high accuracy if there are endometriotic cysts in the ovaries, or there are nodules of endometriosis, deep endometriosis that I mentioned earlier. So imaging is quite accurate in detecting these. And as long as we make use of these technologies, we do not necessarily need to do diagnostic laparoscopies to detect endometriosis, confirm diagnosis. So because of that, in the last ESHRE guidelines that you referred to, we stated that laparoscopy is no longer the gold standard. Laparoscopy is not essential to make diagnosis of endometriosis, because if you see typical endometriotic lesions on ultrasound scan or MRI, then you have your diagnosis, and it's very accurate. So
That's
in
really good.
theory, this should shorten the delay in diagnosis in coming decades.
That's really great news because having a laparoscopy is it's difficult. It's a difficult procedure, isn't it?
It's obvious. It's an intrusive procedure. It requires anesthetic. It requires a surgical intervention. Yes.
We're going to go on to the treatments in a minute, but first, do we know anything about why this happens? Is it genetic? Is it inherited? How does it happen?
Okay. So we don't actually have a definitive reason why some women develop endometriosis. Um, so there are different theories as to how it develops. So the most commonly mentioned theory is that the blood of menstruation, period blood, goes through the fallopian tubes into the abdominal cavity during periods, as well as coming out through the vagina. And the period blood contains cells from the lining of the womb. So it is thought that these cells sometimes attach themselves to the surface of the organs in the pelvis and sometimes in other areas in the abdomen, and that starts the process of endometriosis. So finding period blood in the abdominal cavity during periods is very common. Almost 90% of women will have some blood in the peritoneal cavity. So, but only, as I mentioned earlier, about 10% of women are estimated to have endometriosis. So it's not clear why endometriotic cells attach in some women and continue to survive there in the abdominal cavity in these ectopic external locations, whereas in the others it's clear that endometriosis does not develop. So the theories are that there may be a genetic tendency, genetic background, because if there is a family history, if your mother had endometriosis or your sisters have endometriosis, your risk is like 5 to 7 times higher. So it suggests that there is a genetic background. There are probably some immune mechanisms, immunologic, but these immune mechanism may not be working properly, so that the immune system may be failing to clear those endometriotic cells in the period blood during menstruation, and some of these women may be more likely to develop endometriosis. So there are at-risk women for endometriosis, for example, apart from family history, if a young girl starts periods relatively early, earlier than average, her risk of endometriosis is higher. So early first period, we call it menarche, early menarche, is a risk factor. And if a woman has frequent periods and occasionally prolonged periods, again, they are thought to have a high risk of miscarriage. And you can imagine that if it's related to the period blood going into the abdomen, so then it makes sense that whenever there is more blood present in the abdomen, so that the risk would be expected to be higher. So the epidemiological studies actually do suggest that perhaps women who have frequent periods and sometimes heavy and prolonged periods may be at a high risk of developing endometriosis. There is also some belief that women using tampons may be more likely to develop endometriosis. And again, this may be related to period blood going back more into the peritoneal cavity. Although this research is not very clear or very convincing, so we need to be careful about that and perhaps suggest or avoid suggesting that people should not use tampons as such, because that research is not very convincing.
So there's nothing a woman could do to reduce the risk or prevent the risk of endometriosis?
Okay, well, so there may be approaches, but obviously these are general issues. So, for example, if we look at a century ago, women used to have more children, breastfeed, and during that time they didn't have periods. Hence, in the absence of that, development of endometriosis perhaps was less likely. Whereas now, women have fewer pregnancies, they usually delay pregnancy, and because of that, they end up having many more periods in their lifetime. And then this potentially increases risk of development of endometriosis. Um, in other words, pregnancy has some protective effect. And we know this from epidemiological studies. Being pregnant, potentially breastfeeding, again for the same reason, has some protective effect. Apart from that, there is some evidence, although again not robust evidence, that use of hormonal contraceptives may also reduce development of endometriosis. The reasons for this are not very clear. It's possible that women who are on contraceptives are less likely to have pain symptoms, so they may be less likely to be diagnosed with endometriosis. But it is also possible there is a real benefit, because hormonal contraceptives either prevent periods, stop periods, or they make them lighter. So again, going back to what we said, frequent, prolonged, heavier bleeding is a risk factor for endometriosis. Hence, it makes sense that using hormonal contraceptives may really have some beneficial impact. And then the other thing is obviously now awareness. If we identify people who are at risk of endometriosis, i.e., those who suffer from painful periods from young ages, teenage years, then treating them, even without diagnosis, on the assumption that they may have endometriosis, can potentially help prevent. Although we don't actually have, scientific evidence that this is the case, but there is a possibility, real possibility, that this might be the case. So there are things that they can do. There are also various lifestyle issues that perhaps people can address. Um, the dietary or lifestyle issues and endometriosis connection is a bit controversial. The evidence we have is very weak and not necessarily very convincing. Um, but um, it is possible that um, avoiding red meat or alcohol or um, eh, um, omega-6 fatty acids, these are considered to contain more inflammatory substances. They may potentially reduce the likelihood of endometriosis, but as I mentioned, that the research related to these is very suboptimal quality. Hence, we need to be slightly cautious about strongly recommending them to everyone.
I want to dig a little bit deeper into a couple of things you said, and the first is about the contraceptive, hormonal contraceptives, and having no period. So there are certainly a number of women I've spoken to recently who feel that it's important to have a period and that it's sort of cleansing the woman and sort of resetting the woman. But as you said, historically, women were pregnant more, so they had less periods. So do women need to have a period?
Well, I think the period issues is probably very much related to a number of factors, and culture is probably one of them. In certain cultures, it is a common belief that yes, period is essential in a woman's life. It results in cleansing of the body. But there is no scientific background basis for this. So, strictly speaking, there is no need to have periods. And in fact, historically, as I mentioned earlier, women from a young age onwards were pregnant. They didn't have periods. They had very few periods during their reproductive years. They were either pregnant or were breastfeeding. So, strictly speaking, there is no need for periods as such, and also there is no real need to have period to cleanse your body as such, because there is no such effect. If anything, periods can be associated with certain problems. One is pain, and then the other thing is that sometimes if they are heavy, they can cause anemia, iron deficiency and anemia, and can make a woman's life misery.
They certainly can. Another thing you mentioned was women being pregnant. I'd heard many times that uh, endometriosis can reduce after you've had a pregnancy, but I've got many friends at the moment who have had a pregnancy and the endometriosis has actually got worse. So what's happening there?
Yes. So the impact of pregnancy on endometriosis is variable. Um, it is true that in the absence of periods, some women, perhaps the majority, would feel better, because when there is no period, there is no period associated pain. And then the same impact may be seen during breastfeeding as well. And in fact, these two conditions are the basis of traditional hormonal treatments that we use for endometriosis. Perhaps we'll come to that later on. So the hormonal status in pregnancy and during breastfeeding are potentially beneficial for suppression of endometriosis. But as I said, this impact is variable. Some women may experience the opposite. Some women with endometriosis may see worsening of their pains during pregnancy. So we do not suggest that a woman should get pregnant to treat their endometriosis. Pregnancy should be obviously decided for other reasons, when you want to have a child rather than treat your endometriosis. So pregnancy is not a treatment for endometriosis as such. We should not see it that way, at least.
Let's dive a little bit more into what you said earlier about fertility. So you said endometriosis affects fertility. So do we know what's happening? How does that happen?
So the association with endometriosis and infertility is somewhat controversial, but there is enough data, scientific data, to indicate that women with endometriosis are more likely to experience difficulties in getting pregnant. So in 2016, actually, there was a very nice publication from the USA. They looked at nurses' health register, so identified women who were diagnosed with endometriosis first and followed them through their lives when they started trying for a pregnancy. So they identified that if a woman had diagnosis of endometriosis before starting to try for a pregnancy, their likelihood of experiencing difficulties in getting pregnant was twice as high compared to those who did not have a diagnosis of endometriosis. So it doubles the risk of experiencing difficulties in getting pregnant. So why might this happen? In advanced endometriosis, it's obvious because endometriosis causes um, irritation in the pelvic area. So when there is period, there is usually bleeding from those areas of endometriosis in the pelvic area that causes irritation in the pelvis, and the organs start sticking to each other. So that the fallopian tubes, ovaries, uterus may stick to each other. Sometimes bowel becomes involved. So the pelvic anatomy becomes distorted. If there are cysts in the ovaries, again, the ovaries become enlarged, they swell up, they stick to the surrounding structure so that the fallopian tubes may not be able to pick up the oocytes, eggs released from the ovaries, and carry them effectively to the site of fertilization. So there is a mechanical problem. Another issue might be that because of pain, women may be more likely to avoid sexual intercourse regularly or have less frequent sexual intercourse, and this may also contribute to the difficulties in getting pregnant. So this is when a woman has more advanced endometriosis, when there is mechanical distortion to the pelvic anatomy. But there are situations when endometriosis is relatively minor. Pelvic anatomy is normal. There are spots around the pelvis, but the tubes look normal. They are open. The ovaries look fine. And it's not very clear why these women experience difficulties in getting pregnant. The theories are that endometriosis creates an inflammatory environment within the pelvis, and this inflammatory environment may be toxic or harmful to the process of reproduction. The the tubes may be less likely to pick up the oocyte from the ovaries and carry them to the site of fertilization for various reasons, or the inflammatory reaction results in certain cells in the body eating up sperm, um, more so than women without endometriosis, so that sperm may be less likely to be functional. These are possible explanations when the pelvic anatomy is normal, so that the overall environment that endometriosis generates is still harmful to chances of getting pregnant. And we know this as a fact. Women who have relatively minor early endometriosis are still more likely to experience fertility difficulties, even if their pelvic anatomy is normal.
I've heard some people talk about egg freezing as a way of protecting a woman's fertility if she's got endometriosis. Is that useful or is that not useful?
Um, well, so there may be a place, but obviously its place is still not very well established. So if let's say that fertility difficulties or infertility is like 15% in general population, and then endometriosis doubles it, so 30% in women with endometriosis. So what does that mean? It means that about 70% should, in theory, get pregnant without actually any difficulties, without any help. So majority of women with endometriosis will get pregnant naturally without any help from us. Uh, Therefore, there is no justification of blanket policy that if you have endometriosis, you should freeze your eggs. So that's one aspect. The other aspect is that egg freezing is helpful, particularly useful or effective if you freeze your eggs at a young age. But at the same time, young women are more likely to get pregnant naturally when, as long as they start trying for a pregnancy at a younger age, or even if they don't get pregnant naturally with appropriate treatment, whether this is surgery or fertility treatments such as IVF, they have a very good chance of getting pregnant anyway. So then one questions whether these women should be advised or encouraged to freeze eggs, especially at a young age, because many of these frozen eggs will not be needed, will not be used for fertility purposes because these women would get pregnant. On the other hand, obviously, for older women, chances of experiencing fertility difficulties are higher because of age as well as combination with endometriosis. But then the success of egg freezing at that age goes down. It's not that effective. So in that sense, at the moment, there is some uncertainty as to who should consider freezing eggs and at what stage. So perhaps we can say that if a woman has a diagnosis of endometriosis and she has no, in her early 30s, she has no plans to become pregnant in the following 4 or 5 years, perhaps it may be a good idea to consider freezing eggs while they are still young. But other than that, it is difficult to actually identify a group that we should advise freezing eggs or preserve fertility at this stage. So we need more research. We need prospectively collected data so that we can actually identify who would benefit most, and also in whom it would be most effective. Because if you freeze eggs at the age of 38, the chances of success might be relatively low compared to freezing eggs at the age of 28. So we need to have some across the board data to be able to advise women in the long term. So there are obviously attempts of collecting these data, but it will take some time, some years to actually analyze this, build up the data and analyze this so that we can actually advise women based on scientific evidence.
Yeah, and it's not easy to freeze eggs and very expensive. So we've talked already now about all the
Yes.
complications of endometriosis, but now we're going to get round to the treatments. I listened to your great talk about
Yes.
endometriosis in Turkey recently, and you started by saying in 1919, Thomas Cullen was one of the first to describe endometriosis. And he said, in less than 10 years, I feel sure that the surgeon will recognize and operate on these. So we are more than 100 years later. Why is treatment been so difficult, Ertan?
Obviously, it's a complex condition. I mentioned earlier that there is no direct correlation between the severity of endometriosis and severity of symptoms. And in conditions where endometriosis is quite severe, the treatment can be rather extensive, especially surgical treatment. Thomas Cullen actually was describing the most difficult form of endometriosis, difficult to treat form of endometriosis at that time, endometriosis affecting the bowel, and was referring that surgeons should be able to identify and treat them within the following 10 years. Obviously, we are still debating how to diagnose and then best treat this condition, endometriosis affecting the bowel. So the difficulties are, it is extensive surgery. It requires sometimes removal of part of the bowel, and it may in the long term change bowel functions. And some women actually report that their bowel symptoms are worse following surgery. Although we do see improvement in the majority, it's not always the case for everyone. And then sometimes after effects of this type of surgery can be quite troublesome. So it needs to be carefully selected. And then the other thing is that it's a chronic condition. So when we are talking about treating endometriosis, we are not talking about curing endometriosis. So vast majority of women do still experience some degree of symptoms. So the
Mm.
pain symptoms may improve, but do not necessarily disappear altogether, even if you claim that you've excised, removed endometriosis completely. And then thirdly, there is a high risk of recurrence. So the suggested publications suggest that the risk of recurrence is about 20% after 2 years, 50% after 5 years. So in other words, we are talking about half of women experiencing some degree of recurrence of their symptoms or endometriosis within 5 years following surgical treatment. So these are the complexities. So the other complexity, perhaps even the most challenging complexity, comes from the fact that endometriosis and pain relationship is complex, complicated. So the way that the body perceives the pain, especially if body is experiencing the pain for prolonged periods, actually is difficult to understand. But when a person experiences pain for a long time, the area where the pain originates from becomes sensitized. But the similar sensitization occurs in the central nervous system as well. So the part of the brain starts changing in a way that it learns that there is some irritation, inflammation in a certain part of the body, and in the case of endometriosis, it's usually the pelvic area. So even if you eliminate endometriosis by excising it, your brain continues to think that there is still a problem there. So this is called centralized pain. And because of that, treatments do not always eliminate the pain effectively. Therefore, when we are trying to help women with endometriosis, quite often we need to get input from pain management teams to try to address this concept of sensitization and centralized pain. So this is another factor that complicates the successful treatment of endometriosis.
Complicated, really complicated. You've talked quite a lot about surgery, and I know that there's a long, complicated history around drug treatment of endometriosis. Some that were effective but had too many side effects and all sorts of things. So, where are we today with drugs that will help with this?
Yes. So you remember that I was referring to pregnancy and breastfeeding. So the traditional treatments may be either some use of some hormones or use of painkillers. So for some women who have relatively mild symptoms and who do not want to use hormones, we can just simply use painkillers, and that may be sufficient. They may be happy with that. But for those who are not able to treat their symptoms sufficiently with painkillers only, then hormonal therapies are quite often required. So during pregnancy, both the estrogen and progesterone hormone increase, dominantly the progesterone hormone. And in the past, in my early years in my career, we used to call it pseudo-pregnancy treatment. So in other words, we give hormones, particularly the progesterone hormone, sometimes in combination with estrogen, to create a similar situation to suppress endometriosis. So the progesterone hormone is a key component of treating endometriosis, either on its own or with estrogen. The other option is to suppress estrogen. So breastfeeding does that because the ovaries go to sleep during breastfeeding. And we also know that endometriosis regresses after menopause because the ovaries no longer secrete estrogen. Endometriosis uh, improves and regresses. So we call it pseudomenopause treatment. So that there are therapies, there are medications which switch off the ovaries, create an artificial or medical menopause, and reduces estrogen levels in the body, and that tends to improve symptoms of endometriosis as well as regressing endometriosis. With medical treatments, the principle is that it doesn't eliminate endometriosis, or they don't eliminate endometriosis, but they tend to treat symptoms. And in general, they are successful in a significant proportion. I would say like in the 60 to 70% of women, depending on what therapy we are using. But the issue is that quite often there are side effects, and this usually results in um, somewhat limited compliance. Some women do not feel that the benefits outweigh the potential side effects or the side effects they are experiencing, and end up discontinuing treatment. And sometimes, they switch from one treatment to other until they find a suitable treatment for themselves. But it's not that rare that they actually decide against hormonal therapies altogether. And in that situation, we end up sitting down and thinking about what else we can do, how we can manage endometriosis. For example, there is data about compliance with medical therapies. We actually recently completed a randomized trial of medical therapies following surgery in the UK. We followed women for 3 years after treatment. So we were giving them different forms of progesterone hormone. And we realized that after 3 years, only about 30% of them were still continuing with medical treatment. The rest had discontinued treatment. So it is possible some of these decided to start trying for a pregnancy and may have discontinued, but uh, majority of them would have discontinued simply because they feel that they either do not have enough benefit, or the side effects are more significant than the potential benefit that they are experiencing. So the compliance is relatively low. And from general use of hormonal contraceptives, we know that compliance after about 1 year is about 50%. So half of women who start a hormonal contraceptive method, they discontinue it after 1 year. So this is a well-known fact that we know that hormones can cause side effects, and this can result in discontinuation of the method that they are using. And this applies to hormonal therapies for endometriosis as well.
Yeah, that's what I was going to ask, because surely if they took the injection or implant contraceptive or the Mirena coil, that would that not really help? Wouldn't have periods, so wouldn't that really help their
But
symptoms?
they do. So that they obviously, we know that when there is compliance, if the woman continues with treatment, pain levels improve substantially, especially if periods are suppressed, if we can avoid periods with a method that they are using. And then this is like 60% with the Depo-Provera injections. They stop having periods, about 60% of them, and they will stop ovulating. Therefore, their endometriosis is likely to improve, or the symptoms of endometriosis is likely to improve. But the problem is that not everyone actually continues with that type of treatment because of the perceived side effect that they have. So obviously, as individuals, we look at the reasons why we are using it, and then also the side effects we are getting in return. And then these side effects may be changes in mental health, the changes in mood, feeling bloated or weight gain. So these all affect the compliance, continuation of medical therapies, and inevitably they make some kind of comparison that am I better off adhering to the treatment because I feel a lot better in terms of pain, or I'm better off actually stopping it because I feel worse than I was before starting treatment.
Yeah, it's very individual. I realized when I was on the pill for about 20 years, and I realized when I came off that I'd been probably a bit crazy when I was actually on the pill. And I felt a lot less crazy. My partner might not have agreed with that, but I certainly felt less crazy. So yeah, definitely there are side effects. Now, women that are trying to manage their pain, I've heard about women who are using heat pads, and I was doing some focus groups with 15-year-old girls, and one of the girls told me she had burns on her stomach, and so does one of my friends, and you and I were talking about this in Turkey. So tell us more about these heat pads and why they'd be causing burns.
Yes. So it's not uncommon that women resort to using hot water bottles or heat pads um, when they have pains, particularly during periods. And sometimes pain is so bad that they actually use very hot water bottles or heat pads. And there is a typical appearance because there is some mild degree of burn in the lower part of the abdomen or lower back, wherever they are feeling the pain most severely. And then this is repeated every month. The woman has periods, and over the years, so there is a typical appearance with mild degree of color changes and mild degree of scarring of the repetitive burns, so that I know that person actually is suffering a lot with pain in that area, in those areas. And also I know that those people have been using those heat options, either heat pads or hot water bottles, to the degree that it starts burning the skin. And that's an indication of severity of the pain that they are suffering.
Yeah,
So
for
it has
sure.
a very typical appearance, and you just need to just glance, and then you'll know that there is a likelihood of severe pelvic pain, whether it's due to endometriosis or other reasons.
Yeah, and one of my friends uses a TENS machine as well. Are they effective?
Yes. Yes, TENS machines can be effective. So this is, although the scientific evidence of benefit for specifically for endometriosis is relatively weak. Um, Pain management teams recommend using TENS machines for treatment of pain, whether it's due to endometriosis or other reasons. And it is safer than actually burning yourself with hot water bottles and
Hmm.
heat pads. So they can be quite helpful.
And there's always a market for supplements. And as soon as I started talking to you about this podcast on my social media feed, I started getting all these adverts for endometriosis supplements and powders. So, what about those? Is there a supplement that you can take that's going to cure your endometriosis?
Okay. So obviously, when we cannot cure endometriosis even with very extensive surgery, I think it is
Hmm.
probably far too optimistic to claim that these supplements would cure endometriosis. So the evidence of benefit for supplements comes from theoretical backgrounds. There is no real clinical evidence, scientific evidence that they actually make any difference. So, for
Hmm.
example, I think I mentioned about red meat or fatty acids and various vitamins, vitamin D, E, C. These are antioxidants. Some of them have anti-inflammatory um, uh, roles, and in that sense, considering endometriosis is an inflammatory process, or at least there is some inflammation process during the course of endometriosis, then you can expect benefit. So this is where the claims come from, that endometriosis can be treated by using these supplements, because that this substance is known to have antioxidant benefit. But when you look at real benefit for clinically confirmed endometriosis, um, that is rather poor. And in the ESHRE guidelines in 2022, so not long ago, we looked at all published evidence, and we didn't find any convincing evidence that these make any difference to treatment of endometriosis. But some women find them useful, and in that sense, we don't necessarily discourage them. If they find that they are helpful, they can use them, because many of them are unlikely to cause harm, although there may be some items, substances uh, promoted over the internet that can have real harm. So it's difficult to control that. But going back to what I said earlier, the evidence is lacking. So their support. Um, so I mentioned to my patients that some women find avoiding certain types of food in at least part of their symptoms, some of their symptoms, particularly bowel-related symptoms, because some people find avoiding dairy products helpful, and it's possible that they have some lactose sensitivity. Some people benefit from avoiding gluten-containing food, and then they may have some gluten sensitivity. Um, and if these are helpful, then yes, by all means, it's fine to continue with that kind of dietary approach. But if actually they don't make any difference, they shouldn't feel bad that they are, eating dairy products or wheat-containing products, because it's unlikely that they'll have a substantial impact on their endometriosis or progress of endometriosis.
Thank you for making that clear. And what about endometriosis and fasting?
Okay, again, I think it is the same concept, that it's the theory that fasting may reduce inflammation, and as a result, you expect endometriosis symptoms to improve, or endometriosis to improve. So it's the concept, but not necessarily the evidence. We don't have any
Mm.
evidence fasting makes any difference. So the one thing that maybe it's interesting to mention, that we talked about various risk factors, like starting periods at an early age. The other risk factor, interesting risk factor that we have, is endometriosis is more common in underweight women. Um, it's difficult to know exactly why it is, but it is more common if a woman is underweight. Um, the association with being overweight is not very clear, although there may be a real impact. There are other risk factors. For example, if you're born with low birth weight, intrauterine growth retardation, the risk of endometriosis is higher. Having formula feeding, again, is probably a factor that increases risk of endometriosis in future life. So maybe in the next 10, 20 years, that we will be perhaps targeting these kind of risk factors more often to try to prevent endometriosis in the long term, rather than firefighting after it has developed. So perhaps the preventive medicine approach is going to be an important component of fighting endometriosis in the long term.
Yeah. And let's go now a little bit into menopause. So when a woman goes through menopause, she's going to stop her periods. So does endometriosis stop? And what about if women are taking HR?
So in general, for the majority of women, endometriosis regresses after menopause. It's an estrogen-dependent condition. So when after menopause ovaries stop functioning estrogen, it is common to see resolution of the symptoms or improvement of the symptoms. Having said that, it doesn't happen in everyone. Some women continue to experience pain symptoms even after menopause. There is no guarantee, but majority would improve. So, that there are occasions that rare occasions, you look forward to becoming menopausal, and having a diagnosis of endometriosis might be one of them. So, in terms of HRT, um, so women with endometriosis, in terms of menopause, have a number of important points. So one is that they are more likely to become menopausal at an early age. This may be because they undergo repeated operations, particularly on their ovaries. Sometimes they undergo hysterectomy together with their removal of ovaries because of pain of endometriosis. And in these women, the risk of becoming menopausal at an early age is obviously significant. They are more likely to suffer osteoporosis, brittle bone disease, or cardiovascular disease. So it is important that we provide these women with hormone replacement therapy, at least until the age of natural menopause. The other thing that we know that endometriosis, women with endometriosis are more likely to experience the uh, side effects of consequences of menopause more so compared to women without endometriosis. And again, this may be because of the number of operations, but also because of the medical treatments that they use. For example, using progesterone hormone for prolonged periods, or the medical menopause therapies for prolonged years, may make them more vulnerable to consequences of hypoestrogenism, low estrogen levels. Um, Therefore, even if they go through menopause at the natural age, um, there may be a need to use hormone replacement therapy. After the age of natural menopause, it is optional, but it can be used. So endometriosis in itself is not a contraindication to using hormone replacement therapy. Okay, then what happens? We kept saying endometriosis is estrogen dependent. So what happens when we give estrogen back to them after menopause? Well, it appears that it is relatively safe. There is a risk of recurrent symptoms or recurrent endometriosis, but that risk seems to be somewhere between 3 to 5%. So majority of women do not seem to experience significant significant recurrence of the symptoms. This may be something to do with the fact that with hormone replacement therapy, we are not giving the same level of hormones that the ovaries are producing. So we are giving enough to suppress menopausal symptoms, protect bones and cardiovascular system, but not high enough to support endometriosis or maintain endometriosis or cause its progression. So the current thinking is that we should, if a woman needs hormone replacement therapy after menopause, then it is acceptable to use hormone replacement therapy. One thing is important though, if a woman has a diagnosis of endometriosis, even if she had a hysterectomy, it's important for them to use estrogen and progesterone combination, because normally we wouldn't use progesterone if a woman had a hysterectomy. Whereas if there is a diagnosis of endometriosis, the combination therapy both with estrogen and progesterone should be used,
I
because
didn't know
there is
that.
a high risk of recurrence if you use estrogen on the HRT. And then there is also a theoretical possibility that developing malignancy, cancer, might be higher if you use estrogen on the hormone replacement therapy on the background of endometriosis.
Wow, I didn't know that. Um, Ertan, it's been a bit depressing. Sorry, it's so complicated, and it's not a happy story. But have we got anything in the future? That's what's on the horizon. Have we got anything that you think is going to really revolutionize endometriosis?
Okay. Well, in the horizon, obviously, as I mentioned, that as we now understand the risk factors, that we will probably start talking about taking public health interventions, preventive measures that will target potential risk factors to reduce development of endometriosis. So that's number one, and then that will probably grow substantially in coming decades. So the other issue is that surgical therapies, they are being fine-tuned so that we're hopefully developing better methods in treating endometriosis surgically, with minimizing or lowering the risk of complications and also long-term side effects. And then thirdly, that in the pipeline, there are a number of approaches which potentially treat endometriosis without using hormones. And this may be targeting the process of inflammation. I kept saying that endometriosis has some inflammation process going, and by targeting these inflammatory targets or items in the process of development of endometriosis, we might actually be developing therapies without use of hormones. And what will that mean? Currently, all hormonal therapies are not suitable for women who want to get pregnant, or they do not necessarily improve chance of getting pregnant. Whereas with non-hormonal medications, this may not be the case. That by using these non-hormonal therapies, we might be able to improve their fertility, or they may be able to continue trying for a pregnancy naturally without the fear of, having to use these estrogen, progesterone hormones, which are contraceptives themselves. So these are the areas of potential development: preventive medicine, better surgery, fine-tuned surgery, and new medical therapies which do not necessarily use hormonal medications.
Well, Anya, I'd like to just thank you and everyone around the world who is working on endometriosis. And it is a really complicated disease. And my last question, specifically about endometriosis, my podcast is called "Why Didn't Anyone Tell Me This?" Is there things that women have dealt with endometriosis, and they said, "I didn't know this. Why didn't I know this before?" Have they asked you that?
Well, they do, although this is becoming less common. I think um, now this is becoming part of teaching in particularly in secondary schools. I
Yeah.
think education, incorporation of reproductive health in general, not necessarily just endometriosis, but endometriosis is an important part of that, is being taught is being taught at school, and uh, so therefore awareness is becoming kind of more widespread, that people are usually better informed compared to older generations. Um, but there are also things that we didn't know 20 years ago or 30 years ago either. So we are all learning, the whole process is evolving, and our understanding is also improving as well. Some of the things that we are talking now, perhaps we were not talking about 5 years ago or 10 years ago.
Yeah, it is being taught in schools more, but the survey we did a few years ago of you English schools, we asked, we had a list of reproductive health topics, and I was very sad. It broke my heart that for PCOS, which is our next podcast, and endometriosis, only 2% of kids that filled in our survey, over 1,000 children, aged 16 to 18, said they'd learned about PCOS and endometriosis at school. So I think it's slowly coming, and it is in the curriculum now. So we do have to do it, but we've got a bit of a way to go. And I'm doing some work on helping teachers to make sure young people know about this, because once they know that they shouldn't be having this pain, They're not taught that in some schools, and they know that this pain is not a normal thing to experience. And I think they might go to their doctor more.
Yeah. So I suppose one potential problem that we have at the moment is that, the teachers or people who are going to actually teach these subjects, they need to be armed themselves to be able to teach it. And when they do not have the sufficient adequate background knowledge to teach that, then the outcome may not be satisfactory. I know that Australians actually ran a program some 10, 15 years ago, so that this was a targeted program. So schools had certain projects teaching reproductive health, including endometriosis, and this obviously improved awareness substantially. So perhaps it needs to be run as part of a project. Perhaps people with the relevant knowledge, sufficient knowledge, actually should actually teach these subjects rather than expecting all teachers to know this subject and teach them at schools.
Yeah, our bit of good news is that we feel teachers can teach the basics for sure. So our international reproductive health collaboration is we have produced an information leaflet on PCOS and one on endometriosis, and we're part of ESHRE, so it's all coming from the same thing. And we have also produced a PowerPoint research tool for teachers, and there are slides on endometriosis and PCOS just to get those conversations going. So we are arming the teachers. We've been working on that. So we really hope that if we did our survey again, 100% of young people would say they've learnt about endometriosis and PCOS, which I think, going back to the very beginning, this will really help speed up women being diagnosed with this. I'm going to
And I
finish
hope
on.
so. I hope you
Yeah.
have success.
I hope so too. Ata, we need to finish on something happy. So I ask all of my guests happy questions at the end. Ertan, what makes you happy and where is your happy place?
Oh, well, what makes me happy actually is to get an email or letter from my patient that I treated, um, to tell me that, um, if they were experiencing difficulties in getting pregnant, that they are now pregnant. Sometimes they actually write to me after 3 pregnancies, after 3 children, saying that, oh, well, you might not remember me, but you actually operated on me 10 years ago, and I now have 3 children. I need
Oh,
contraception, uh, type news. Um, or they say that that their pain improved substantially, so that they can get on their life. So this kind of positive news keeps me going, keeps me very happy. And where I am happiest is home, really, with the family. Uh, I love being at home, in the family environment.
fantastic, fantastic. And the very final question, again, I ask everybody because now we're all a bit wiser and hindsight's a great thing. But Ertan, what advice would you give your younger self?
Um, well, I think I would do it all over again. The process that I followed, I wouldn't want to change anything substantially. Obviously, we all make mistakes, and I'm sure we will continue to make mistakes. The important thing is to learn from our mistakes and try to reduce that likelihood, so that we can better ourselves as well as continuing to help other people. So, in that sense, I don't have major regrets in life. Um, I would do it all over again the way that I did.
That's a fantastic and very, very positive way to end what's been I think that's been the toughest podcast to record and listen to, because it's really problematic. I think endometriosis is such a difficult disorder for anyone to deal with. So, and you are really one of the world experts. So, Ertan, thank you so much for giving up your time and recording this podcast with me.
Well, pleasure. Thanks for asking me to do this podcast with you, Joy.
Thank you. Bye.
Bye-bye. Bye.